Hello everyone, myself Hisana Valliyath, Assistant Professor, Department of Anaesthesia and OT Technology, Yenepoya School of Allied Health Sciences. Today, my topic is Artificial Airways. So before going to the session, let me tell you what are the specific learning objectives. Upon completion of this session, any student who is watching this video should be able to list the types and uses of airways, explain and demonstrate the proper insertion technique of airways, enumerate the precautions to be taken during insertion of airway, and list out the possible complications of using airways. So what is an airway? An airway is a device which helps to maintain the patency of air passage for an unobstructed breathing or easy breathing. Unlike other maneuvers to maintain a patent airway, including chin lift, jaw thrust, and tracheal intubation, insertion of an airway does not affect the stability of cervical spine. Basically, airways are of two types, that means oropharyngeal airway and nasopharyngeal airway. The example of airway is that is a type of airway which is called as Gudel's airway, and the other one is nasopharyngeal airway. An oropharyngeal airway has a flange, bite block and a curved oropharyngeal body. This flange is used to ensure that it does not move into the mouth or the patient does not swallow the airway. The bite block prevents the patient from biting and kinking the airway. So this is an example for oropharyngeal airway which is called as Gudel's airway. It is made up of black rubber. You can see the flange, bite block and body. The commonest type of oropharyngeal airway used is Gudel's airway. It is disposable and is available in various sizes in various color codes. Other types of oropharyngeal airways used are Waters airway, Suffer's airway, Connell airway, Phillips and Berman's airway. So this is Suffer's airway, Waters airway, Connell airway. These are differentiated into various names because in this Connell's airway there is multiple holes at the pharyngeal end. Now coming to Gudel's airway, which is the most commonly used one. There are three parts which I have already told: body, bite block and flange. This body and bite block have the lumen that keeps the airway patent. Bite block is reinforced with hard plastic which prevents the airway from collapsing when the patient bites it. The flange prevents the airway from slipping into the mouth. You can see the parts of a Gudel's airway. At the buccal end there is a flange, bite portion and an air channel. This bite portion and air channel is having a patent lumen which helps to maintain the airway patent. See, the color codes of oropharyngeal airway varies from pink to red. The smallest one being the size 000 is for neonates and the largest one is for large adult. So you can identify each sizes by their color codes. Uses of oropharyngeal airways are: it prevents obstruction of the upper airway by lifting the tongue and epiglottis away from the posterior pharyngeal wall. That means it prevents the tongue from going back and blocking the airway. It prevents biting and occlusion of orotracheal tube. So whenever an intubated patient is coming out of anesthesia, there is a high chance for the patient to bite and occlude the orotracheal tube. So this airway, when inserted, it prevents the biting and occlusion, and then it protects the tongue during biting and seizure activity. During seizure activity, there is a high chance for the patient or for the victim to bite the tongue and cause injury. So when an airway is inserted for those patients, it protects the tongue during biting and seizure activity. Other uses are: it facilitates oropharyngeal suctioning because it has a proper lumen inside. It provides a better mask fit for ventilation, and also it helps to insert tubular devices through it into esophagus and pharynx. Now, how to choose the proper size of airway? In case of oral airway, it should be placed on the patient's mouth as seen in the picture. It should extend from the lips to the angle of mandible. Now the technique of insertion. The preferred technique is to use the tongue blade to depress the tongue and insert the oral airway posteriorly. So instead of using this tongue depressor, you can also use a laryngoscope. An alternate technique is to insert the oral airway upside down until the soft palate is reached. As you can see in the picture, while inserting, it is inserted upside down. Once it reaches the soft palate, it is rotated 180 degree and then inserted as such. So after inserting, it should be like in the second picture. There is another type of oral airway called Berman airway. This is also almost similar to the Gudel's airway, but it has a median septum with multiple openings inside and has a deep groove on the either side. It is also available in various sizes and color codes. It is a type of airway which is becoming popular nowadays, and the shape is similar to that of Gudel's airway, which I have already mentioned. The main advantage of using this type of airway is the chance of block of the airway by secretions is less, and it is very easy to clean compared to Gudel's airway. Now coming to the complications, always remember, before inserting an airway into a patient, confirm that he is unconscious, because if a patient is semi-conscious and his gag reflex is intact, insertion of an oral airway may not be well tolerated. It might even initiate vomiting and lead to aspiration. And there are also chances of iatrogenic trauma such as pinching of lips, tongue and dental injuries. After prolonged insertion, there are also complications like tongue necrosis, edema, uvular edema or lip damage. There is also chance of tracheal bleeding, oral infections or mouth sores if it is used for prolonged period. Now coming to nasopharyngeal airway, it is a soft tube designed to be inserted into the nasal passage to secure a patent airway. It is passed through either of the nostrils and relieves obstruction due to tongue and epiglottis. It is also used in conjunction with oral airway if the latter is not effective in clearing the airway. It is useful in patients who have limited mouth opening or any pathology of oral cavity that makes it difficult to insert the oral airway. This airway is better tolerated by semi-conscious patients and even conscious patients. Other uses of nasal airway are during pharyngeal surgery, fiber optic bronchoscopy, or to apply continuous positive airway pressure and facilitate suctioning. So coming to the description, it is a soft C-shaped tube made of latex, red rubber or silicone. It has either a fixed or adjustable flange at its proximal end and a beveled distal end. It curves to fit the curvature of nasopharynx. It is available in a range of lengths and internal diameters which is suitable for patients. Now coming to indications. When do we use a nasal airway? Nasal airway should be used if the patient is conscious, semi-conscious, or it can be used for unconscious patients also. When a patient's mouth is difficult to open or access, or when an oropharyngeal airway cannot be inserted, or when their gag reflex is intact, massive trauma around the mouth is there, nasopharyngeal airway should be used. How to choose a proper size of airway? So in the proper size of nasal airway should be checked by measuring it by keeping it on the patient's chin. It should extend from the nostril to the earlobe or angle of jaw as seen in the picture. Now the technique of insertion of a nasal airway is use a nostril that is unobstructed. Any tube inserted through the nose should be well lubricated and advanced at an angle perpendicular to the face. The device is inserted until the flared end rests against the nostril. As you see in the picture, before inserting the tube, it should be lubricated well and the proper size of the airway should be taken, and it is held by keeping it perpendicular to the face. It is inserted gently and till the flared end rests against the nostril, it should be inserted. If the length is more, you can also use a safety pin which is passed through the tube at the proximal level to fix the tube from slipping into the nose. Now coming to the types of nasal airways, there is Bardak's airway which is made up of red rubber. This is Bardak's airway. Next is binasal airway. It looks like two nasal airways joined together through a connection. It can be inserted into both the nostrils at a time. And there is another type of airway called cuffed nasopharyngeal airway, which looks same as like cuffed orotracheal tube. And next is epistaxis airway. It is another type of nasal airway which helps to prevent nosebleeds. It can be inserted when there is epistaxis. So it applies a local pressure over the mucosa, nasal mucosa, and it helps in providing a patent airway. It is also available in different sizes. This is how an epistaxis airway looks like. So it should be, before inserting, it is deflated, and once it is inserted, it should be inflated through the inflating tube. This is another type called Linder nasopharyngeal airway, in which a stillet is used to be inserted. Coming to the precautions to be taken during insertion of the airway, pharyngeal and laryngeal reflex should be depressed to prevent coughing and laryngospasm. That means whenever an airway is inserted, this laryngeal and pharyngeal reflexes should be depressed by using drugs. Appropriate size must be used by measuring it from the patients. Airways must be inserted after lubricating with jelly. Now, the possible complications of using a nasal airway is airway obstruction, epistaxis, trauma to the lungs. Now, the possible complications of using a nasal airway is airway obstruction. If larger sized airway is used, it may also act as a foreign body in the airway. Epistaxis, trauma to the septal mucosa, nasal polyps or adenoidal tissue can cause nosebleeds. Another complication is trauma to the tongue, nose, uvula, pharynx and teeth. Long oropharyngeal or nasopharyngeal airway can cause laryngospasm also. Before inserting, we have to make sure that the patient is not allergic to latex materials. In that cases, patients can cause latex allergy. Another is tissue edema, ulcers and necrosis can happen. If the patient is having basilar skull fracture, there is a high chance of getting trauma to the central nervous system when airway is inserted. And there is another chance of retention, aspiration or swallowing of the airway. So all these chances should be taken care of. Now let me summarize the session. A clear patent airway is a fundamental requirement for effective resuscitation. Airway adjuncts are used to relieve or bypass an airway obstruction during airway management. Oral and nasopharyngeal airways constitute an important mandatory accessory in airway management. An oropharyngeal airway is an airway adjunct used to maintain or open the airway by stopping the tongue from covering the epiglottis. The purpose of nasopharyngeal airway is to bypass upper airway obstruction at the level of nose, nasopharynx or base of the tongue. So before insertion, you have to always take precautions such as proper size of the airway should be used, properly lubricate the airway which is taken, and make sure the patient's laryngeal and pharyngeal reflexes are depressed. Before using an oral airway, make sure the patient is unconscious, and for nasal airway, it is okay if the patient is conscious or semi-conscious. So these are my references. Thank you so much.